Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
And thank you for joining us. My topic today, what I want to talk about is the patient with systolic dysfunction who is continuing to progress and has what we would call advanced heart failure or end-stage heart failure or refractory heart failure, lots of terms. But the American College of Cardiology and the American Heart Association has agreed that to call these patients stage D, or patients with truly refractory heart failure, end-stage heart failure, who have a very guarded prognosis and who need to be considered for life-saving advanced therapeutic options when they reach this stage, if they're candidates. So that's what I'm going to take you through. I think this is an exciting time in the field of heart failure, not only because of very effective medications that have changed the natural history of the disease, but also we now have incredibly viable options to help these folks, including mechanical circulatory support that can be long-lasting or temporary, and obviously transplantation. And I'm going to share some of that with you and some of the excitement in the field. I have no disclosures or conflicts of interest that impact this talk. So I'm going to take you, this is an outline of what I would like to do today over the next 30 minutes or so, is to give you a sense of who these patients are, what the options are, both from the medical side and the surgical options, including transplantation and mechanical circulatory support. But I think importantly, helping you to identify these patients, to raise awareness, and to identify these patients before it's too late to offer them life-saving therapeutic options. So I'm going to take you through who might benefit, why they should be considered, when somebody should be especially referred to an advanced heart failure specialist for consideration of these therapeutic interventions, and then just take you through what some of these options are. And if anyone has any questions, I'll be delighted to take them and try to answer them. One of the things that we have to try to understand is the epidemiology of heart failure and cardiovascular disease. And I think over the past several decades, with the hard work of many physicians and scientists, mortality from cardiovascular disease, mortality from myocardial infarction and stroke has been declining around the world, especially here in the United States. But what happens is that once that patient survives their heart attack because they have a STEMI and now they go to the cath lab and they have their LAD stented, unfortunately, many of these patients will continue to progress, and then later in life, 5, 10, 15 years later, unfortunately will present with heart failure. So that the epidemiology and the prevalence of heart failure around the world continues to increase. And it's one of the epidemiologic facts that has continued to place a significant burden on healthcare systems, especially in the United States, but around the world. It's a disease whose prevalence continues to increase in part because of successes in life expectancy. You know, now with excellent medical therapy, with preventive medicine, patients are living longer, and heart failure is a disease of the elderly. So as you continue to survive your heart attack, your stroke, or you continue to get older in age, the prevalence of heart failure increases. And as one gets older, the prevalence increases, so that the incidence of heart failure around the world continues to increase because of successes in cardiovascular medicine and because there is a graying of the population around the world, especially in developed countries around the world, so that we're seeing an increase in prevalence and an increase in the incidence of this disease. So this is something that every physician needs to be attuned to and aware of, because they will be seeing a significant number of patients in their practices with heart failure. So why is this important? And it's important because heart failure is a progressive problem, and it's one of the lessons that I would like to sort of leave you with today, that this is a progressive disease, unfortunately. And this is the ACC, American Heart Association, staging system for heart failure, from stage A, B, C, to refractory heart failure, or end-stage heart failure, stage D. And I think the important thing about this staging system is the concept that heart failure is a preventable disease. So for example, that patient who's in his or her 20s or 30s, who may have hypertension or diabetes, that person has not developed heart failure, but is at very high risk for the development of heart failure. So it's clear that that patient, if treated aggressively, there's overwhelming data that the incidence or the prevalence of heart failure in that patient population can be impacted upon significantly with treatment of their hypertension and their diabetes. So it's a preventable disease, but unfortunately, most of us in practice, especially cardiologists, will see patients who present in stage C heart failure, who get admitted to a hospital with decompensated heart failure, with structural heart disease, and that can be ischemic heart disease, valvular heart disease, patients with dilated non-ischemic cardiomyopathies, or a host of other forms of structural problems of the myocardium that can lead to heart failure. Around the world, one of the most important parts of all of this is hypertensive heart disease and patients with heart failure in the setting of preserved ejection fraction. That's a significant proportion of the heart failure population that we see here in the United States and is true around the world. But one of the things that happens, unfortunately, is that these patients progress from stage C to stage D, and it's unpredictable how these patients predict. Every patient will progress differently. But the one thing I want to leave you with is that patients who are stage C transitioning to stage D or refractory heart failure have an incredibly high mortality. More than 50% of those patients are not alive at 1 year. And these are the folks that are admitted and readmitted to hospitals and consume a significant proportion of the resources of healthcare systems. So this is an important patient population to identify, and if appropriate, they need to be referred to centers that can offer advanced therapeutic options to not only improve the quality of their life, but also save their life if appropriate. So the staging system is very important for patients and for physicians who care for these patients. Now this was just published, and I want to make one point on this slide. And this is from Get With the Guidelines here in the United States. It's a large registry of patients who were admitted to American hospitals with acutely decompensated heart failure. Most of the patients were over the age of 65, so this was a Medicare database in the United States. And one of the important points that I want to make, which was incredible to all of us to see this data, is that if you see if you notice the graph, the 5-year survival of all of these patients, the cumulative 5-year survival of these folks was 20%. So there was approaching an 80% mortality. at 5 years for these patients who were admitted to American hospitals with one episode of acutely decompensated heart failure. I think that we should all step back and really think about that the majority of these folks, after one hospitalization, the majority of these folks are not alive at 5 years, and the 2-year mortality is approaching 50%. I mean, to me, I think that's incredible. It's hard to believe, but it's the reality of these folks. These are sick patients. And one of the important things about this database also is that these patients not only had reduced ejection fraction, but also had preserved ejection fraction. So that ejection fraction did not appear to be an accurate biomarker of risk stratification. So the fact that these patients were admitted with heart failure alone was a significant risk stratifier, and thus identified patients that their 5-year mortality was excessive. So this is an important fact that I think that all physicians should be aware of who take care of these patients. These patients are sick and will continue to progress and have an incredibly bad outcome at 5 years. And this was also depicted in this classic trial that's now over a decade old, which was the rematch trial, which was, I think, one of the most important clinical trials of our in modern medicine recently, at least in cardiovascular medicine. And it was a proof of concept trial which showed that patients who are truly end stage, New York Heart Association functional class 4 or stage D, at the end had a 1-year mortality that basically was 100%. So the majority of these folks who were truly advanced heart failure, stage D, on optimal medical therapy, had a 1-year survival that was barely 10%. So these patients in your practice, and they're in your practice, need to be identified early and need to be referred to centers that can have an impact on this natural history. And one of the things that I want to point out in this talk today is that there are a lot of options for these folks. The future is bright. There are lots of options for these patients, and I think that identifying them and getting them referred becomes very important. So what are the therapeutic options for these folks? Well, there's mechanical circulatory support, either as what we would call in the United States destination therapy for a patient, for example, that is not a transplant candidate. There's also bridge to transplant, so someone who is pretty sick but can't get transplanted currently can be bridged to transplant with mechanical circulatory support. And there's obviously the best therapy for these folks, which is orthotopic heart transplantation, but unfortunately, the number of donor organs in the United States and around the world is quite limited, and so that we cannot meet the demand for folks that have end-stage heart failure. And for those patients that truly are not candidates for these advanced options, I think that the transition to death should be peaceful, and that's where palliative care and hospice medicine become very important. So a true advanced heart failure program will incorporate all of these options in the care of their patients. So who would be a candidate? I think the important thing is that the patients not progress to the point where they have significant end organ dysfunction, meaning that they've had a stroke, their kidneys are failing, their liver is failing, they have significant frailty. So the point is to identify patients early before their end organs have suffered irreversible damage. Now this slide is a little busy, but I think that this is important. These are the definitions of advanced heart failure, not only the American guidelines, but also the European guidelines in terms of who may be a candidate for consideration of advanced therapeutic options. But I think the bottom line in all of this, it's fairly straightforward. It's a patient who has heart failure, systolic dysfunction, who has been admitted to the hospital or readmitted to the hospital, who tells you, "Doc, I can't walk 1 block without being significantly short of breath." And then objective data, someone with an ejection fraction that is, say, less than 20%, or a oxygen consumption on cardiopulmonary exercise stress testing that is less than 12 mLs per kilo per minute, Those are, I think, important aspects of identifying someone whose mortality at 1 year is incredibly high. Another thing is those folks with hyponatremia or patients whose defibrillator continues to go off. These are high-risk individuals who should be considered as high risk with significant heart failure, who should be considered for advanced therapeutic options. So those definitions are there for your review. I summarized many of those from the guidelines here, but those advanced heart failure, true advanced heart failure, again, is those patients who get admitted and readmitted who have episodes of significant dyspnea, especially when they say they can't walk 1 block or to the mailbox or can't chase after their grandkids. Certainly patients who are on inotropes. And I think importantly, something to think about are those patients where you've had to withdraw life-saving medications like ACE inhibitors or beta blockers because they cannot tolerate them. They're hypotensive or they're lightheaded or their renal function gets worse, and you're having to withdraw or decrease the doses of these life-saving medications. That's an important red flag that should identify these high-risk individuals. So this is here for your review, but these are patients that I'm sure that all of you, especially in cardiovascular medicine, probably see on a daily basis. So the advanced therapeutic options are here, and they're exciting. This is an exciting time to be, especially a heart failure doctor. We have great technology to help these folks, and transplantation has gotten to the point where it's certainly no longer investigational. Now it's the standard of care for patients with advanced heart failure. And in fact, this is this month, January 2018, was the 50th anniversary of the first heart transplantation that occurred in South Africa, and the 50th anniversary of the first heart transplant in the United States. So it's an exciting time to be part of this field, and it's exciting for patients because there are options to help them. The important thing that I want to take you through is sort of in your practices, the practical aspects of all of this. And I think the important thing is there are many patients who are stage C who you see every day, especially if you're a cardiologist. Someone who's got symptomatic heart failure that's been admitted to the hospital or, for example, has presented to your office, short of breath with evidence of heart failure. And how we can identify these folks as they're transitioning from stage C to stage D, which is very, very difficult. Every patient transitions at a different stage and at a different rate. But there are some clues, and I'm going to take you through some of these clues because they're helpful clinically. It would be nice if we had a biomarker or if we had something that was pathognomonic for that transition from stage C to stage D, but we do not. And I think a lot of this is being a good clinician and knowing some of the signs and symptoms and markers that identify these high-risk individuals. Because once these patients begin to transition from stage C to stage D, they enter a spiral that is sometimes very difficult to get out of, and their mortality is excessive. So trying to identify them before they fall off the cliff per se becomes very important. And this is some of the things that we had discussed already, some of the clues that we use. You can use some of these survival scores. They're clinically at times useful. I don't find them to be clinically useful every day in practice, but they are available on the internet to give patients a sense of their mortality and to help physicians guide timing of referral. But I think the most important things are hospitalizations, serum sodium, and then objective markers like your creatinine or your peak VO2 on exercise treadmill testing. One of the most important clues is repeated hospitalizations. So for example, those patients who come into the hospital with one episode of heart failure is at very high risk. I already showed you the Medicare database in the United States where the 5-year survival is approaching 20% only and the mortality 80%. But you can see in this graph that as patients are admitted and readmitted to hospitals, their mortality increases significantly. It's not clear what it is about the hospitalization that worsens mortality, but it's clear that these patients are progressing and that their heart failure continues to progress, and that has a negative impact on survival. So hospitalizations are an important clue that these are sick individuals that should be identified and perhaps, if appropriate, referred for advanced therapeutic options. The other thing is renal function. The cardiorenal syndrome, or the interaction between the heart and the kidney, is complex, and I don't have time to go into that today, but patients who, for example, you have worsening renal dysfunction, and you have to lower the dose of their ACE inhibitor because their creatinine is climbing, or have worsening renal dysfunction, or the kidneys are limiting your ability to add, for example, spironolactone because your creatinine is elevated or their potassium is elevated. That's a high-risk individual. And you can see here that renal limitations on these patients, allowing to add life-saving medications, impacts their mortality significantly. So the cardiorenal syndrome is a marker of a sick individual with a guarded prognosis and someone who may need to be referred for advanced options. So another clue to help practicing physicians. For those patients who have needed inotropic support, either intermittently or chronically, to palliate their symptoms and to keep them out of the hospital, that's an incredibly high-risk individual. And you can see that patients who have been started on inotropes, their one-year survival is barely 10%. So the fact that someone needed an inotrope to overcome their acute episode of heart failure, or were deemed dependent on inotropes and sent home on inotropes, that's an incredibly sick individual that should raise a red flag, and that person should be referred sooner rather than later for consideration of advanced options. Now, one of the most important things that is very difficult, and for the cardiologist in the audience, they know this all too well, is the right ventricle. We always focus on the left ventricle, but when the right ventricle begins to fail, mortality is incredibly excessive, and patients are incredibly ill with renal failure, liver failure, frailty. So one of the things that becomes very, very important is to try to prevent or delay the development of right ventricular failure, because once the right ventricle begins to fail, these patients are incredibly symptomatic. They're hospitalized repeatedly. Their liver is congested. They may get cirrhosis of the liver. Their gut becomes congested. They become malnourished, frail, and their kidneys begin to fail. So the right ventricle and preventing right ventricular failure is one of the most important things that we as cardiologists try to prevent. And we need to refer patients for a consideration of advanced options before the right ventricle begins to fail. So for those patients who present with edema, liver congestion, abnormal LFTs, frailty, malnutrition, worsening renal function, you can bet that the right ventricle is beginning to fail, and that's a very sick individual who needs quick referral to a program that can help with advanced options. So this is a summary of what I've just discussed for your benefit in terms of who these high-risk individuals are, and you can read the list, but I think the important thing that from a practical perspective is that patient who is admitted and readmitted, and the patient where you're withdrawing life-saving medications because of either worsening renal dysfunction or hypotension or other end organ manifestations that do not allow you to add life-saving medications like ACE inhibitors, beta blockers, or mineralocorticoid receptor antagonists. That's a high-risk individual that should be referred. And those are clues to help you in your practices when you take care of these patients. When should they be considered? Well, that is not an exact science, and that's where good clinicians come into play. We can use many of the things that we just discussed, the clinical clues and some of the objective data, but I think it becomes incredibly important that we do not wait until the patient is too sick. When the patient is too sick, the options are very few. When multiple organs begin to fail, the options are very few. So the optimal timing is when the patient is sick, but not too sick. And it's better to refer earlier rather than later. And you and your colleagues, your heart failure colleagues, can work collaboratively to help take care of these patients and follow them. So that the window of opportunity, this window of opportunity that we talk about, that every patient has for being considered for advanced options, is not closed because they become too sick. And these patients can become sick very quickly, as many of you have seen taking care of many of these folks. So it's important not to allow the patient to get too sick. And this is a patient who has progressed, who is obviously very sick, who's got a peripheral edema, who's frail, malnourished. This is a patient that we cannot help at this stage. This is a patient whose mortality is very high, who would not be a candidate for transplantation or mechanical circulatory support. So it's our goal as physicians taking care of these patients not to allow these patients to progress to the point where they're too sick and too frail, and life-saving options are no longer options for these patients. So what are the options for these folks? And I think that the only options for these folks, once they enter true stage D or New York Heart Association functional class 4 heart failure, is transplantation, which is no longer investigational, but the option of choice. But unfortunately, here in the United States and Canada and around the world, there's a limited number of donors, so we cannot help all of the patients with stage D heart failure. But ventricular assist devices have been established to meet this demand, and are now to the point where many patients can be helped with mechanical circulatory support, either as destination therapy or as a means to bridge them to transplantation. So let me just review transplantation for you quickly. It is really the treatment of choice for these folks. We're celebrating the 50th anniversary, or we did celebrate the 50th anniversary of the first heart transplantation performed in South Africa in 1967, and we just celebrated the 50th anniversary of the first human heart transplant in the United States this January, on the 6th of January, which was done at Stanford University. So transplantation has come a long way, immunosuppression has come a long way, and this has become the standard or the best treatment for patients with end-stage heart failure. But as you can see from this graph, the number of donors in this country and around the world continues to be flat, despite raising awareness and despite aggressive means of trying to expand the donor pool. Unfortunately, the donor pool has remained flat. So we can only help here in the United States about 2,500 individuals with end-stage heart failure per year. And there's an estimate that there's somewhere between 200,000 to 300,000 patients who can be helped by transplantation every year. So you can see that mechanical circulatory support is the bridge or the technology that is necessary to help many of these folks that we cannot help with transplantation. I'm going to show you this slide because transplantation today, survival in a center with high volume, in a center that knows how to do heart transplantation, survival today, the median survival of someone who is transplanted today in the United States, for example, approaches 13.1 years. That's an incredible, we've come a long way in 50 years, and much of that is surgical technique and immunosuppression. So heart transplantation is a very accepted method of treating these patients. But unfortunately, we can't help all of these folks, and if we can't transplant them, then what? You can see this is national database here in the United States where we really can only help about 13% of the folks with end-stage heart failure. So, and it's estimated that only about 1.3% of the folks can be helped with transplantation in the United States with advanced heart failure. So that leaves a lot of individuals who cannot be helped by transplantation, but mechanical circulatory support is poised to be the treatment of choice in many of these patients to help them rescue them, improve their quality of life and their survival. And the technology has come a long way in the past several decades, and mechanical circulatory support is now poised to become the standard of care for many patients with stage D heart failure, and to meet that demand that heart transplantation cannot meet. So we've come a long way from medicines, and we got great medicines in the armamentarium to take care of patients with heart failure, to machines and mechanical circulatory support devices. And now I'll show you this landmark trial, which I mentioned earlier, which was the ReMatch trial, which was the proof of concept trial that showed that mechanical circulatory support can improve survival in patients with end-stage heart failure. And you can see here the marked increase in survival in someone who received the first generation mechanical circulatory support device, or the Thoratec device, which was the HeartMate 1. This was a bulky device. It had ball bearings. It had technology that is now old and obsolete. And as you can see from the graph, at about 2 years, many of the patients who had this mechanical device died. And they died because the LVAD failed. And that was because of the technology at the time and the failure of many of the parts in that in the device. We've come a long way since then. The devices have gotten smaller. There are now no wearable parts in many of the devices that are now FDA approved in the United States. This is an axial flow pump. This is a centrifugal flow pump. These are magnetically levitated centrifugal pumps, and ideally can last forever because there are no wearable parts, and can provide 5 to 10 liters of flow. So these devices are life-saving and have significantly improved our ability to take care of patients with end-stage heart failure, and they're a viable option for these patients. And the majority of these patients improve their quality of life. Many go back to work, and their survival is significantly impacted upon for those patients who are candidates for this type of device. The newest type of device is magnetically levitated. It's the HeartMate 3, which is approved in the United States recently, and there's been a decrease in the hemolysis and thrombosis. So the technology has come significantly improved over the past several decades, to the point now where we have devices that are very small and can provide up to 5 liters of flow and improve the quality of life of these folks, and have significant improvement in survival, almost to the point where these devices are as good as transplantation in terms of survival. So the 1-year survival for patients on devices is approaching 90% in the United States and around the world. And remember that these folks, at 1 year, barely 10% of these patients were alive. So for those patients with true end-stage heart failure now who receive these devices, as we get better in taking care of these patients and as surgical technique improves, more than 90% of these patients are now alive at 1 year. And it's approaching a 75-year, 3-year survival. So 75% of the patients are alive at 3 years with excellent quality of life. So this is a viable option for your patients. So we should see this not as a last-ditch effort, but we should see this as a bridge to life. These are life-saving technologies that can improve quality of life and survival. And for many patients, it is a godsend and a gift of life. So do not see these devices as a last-ditch effort. These are really now becoming the standard of care for many of the folks, since transplantation cannot meet the demands of the majority of people in this country or around the world because of the increasing prevalence and incidence of heart failure, and especially end-stage heart failure. So this technology has now been written into the American guidelines for patients with heart failure. So this is now and will become probably a Class 1 indication when the new guidelines revised. It has become a class 1 indication in Europe and the European guidelines. So this technology now is to the point where it's been written into the guidelines in the United States and in Europe. So these are viable options for your patients that should be considered as these patients progress, and should be referred to institutions that can provide these life-saving technologies. Unfortunately, there are complications that we all need to be aware of, and patients need to be aware of. We have not solved the problem of pump thrombosis, even though anticoagulation has gotten much better and the surfaces have gotten much better, and we've been able to decrease pump thrombosis significantly. It is still a problem. Stroke is still a problem. It occurs in about 10 to 15% of patients, although with improved anticoagulation and improved technology, this will continue to improve over time. And then the holy grail of mechanical circulatory support is to make this completely implantable with transcutaneous energy transfer. Unfortunately, a drive line still comes out of the body, connected to a controller and a battery, but this eventually will be solved by making all the devices and all the parts totally implantable as battery technology improves and we can transcutaneously recharge these batteries over time. So for those patients, unfortunately, who are not candidates for whatever reason for mechanical circulatory support or orthotopic heart transplantation, these patients have a horrible prognosis, and palliative care and hospice should be part of the treatment plan. End-of-life discussions need to be considered, and patients need to be aware of these options, and palliative care medicine should be involved so that the transition to death becomes very peaceful for these patients and their families. So that you can see that the paradigm, there's been a paradigm shift in thinking, and I think that this is important not only in the United States, and many centers are changing their paradigms, but around the world where palliative care no longer should be involved when the patient's on their deathbed, but should be involved very, very early on in a patient who has heart failure, understanding that the natural history of this disease is progressive and that this is a terminal illness. So palliative care should be involved early so that they can help the family and the patient move through this journey as they progress in their lives, and when appropriate are involved in the transition to their death if that occurs in your patients. So palliative care medicine is a very important part of the team and should be part of any good heart failure program. The transition to death should always be peaceful, and I think that's where palliative and hospice medicine and our colleagues in hospice medicine are very important. So that transition is not painful for the patient or the family. So let me just conclude, and I hope I've given you a sense that these are exciting times for patients and for those of us in cardiovascular medicine who take care of patients with heart failure. It's exciting because we now have options to help these folks that can improve their quality of life and extend their survival. And I hope that I've left you with a sense that when you meet that patient with heart failure, that these patients are sick, that the natural history can be altered with appropriate use of evidence-based medical therapy that is guided by the evidence and by the guidelines. But unfortunately, many of these patients will continue to progress. And when they do progress from stage C to stage D, that it becomes important that these patients be identified and referred for consideration of these advanced therapeutic options. And the other point that I want to leave is that palliative care medicine is incredibly important and needs to be involved in any good heart failure program, and that we understand that the epidemiology of this disease is changing not only in this country but around the world as patients live longer and cardiovascular advances continue. Patients will survive their cardiovascular events, but unfortunately later in life will present with advanced heart failure. So hopefully this has been helpful and and it's been practical to try to help your patients with heart failure. And thank you for inviting me to do this. And I want to thank Philadelphia International Medicine for inviting me to give this talk today. So thank you very much.